We've been working on the topic of trying to induce apoptosis in patients with acute myeloid leukemia, and the tools we've been using include drugs called BH3 mimetics, which are small molecules designed to target BCL2, which is a critical survival factor in AML. We've previously done studies where we've combined low-dose Ara-C in combination with venetoclax in patients aged 65 years and older as first-line therapy for AML, and there were quite promising results observed with that. With the abstract that we presented at EHA this year, our goal was to see if fitter patients with acute myeloid leukemia could tolerate venetoclax in combination with intensive chemotherapy. And so for this, we conducted an investigator-initiated clinical trial, doing a dose escalation of venetoclax and combining this with intensive chemotherapy. For this patient group, which was again over the age of 65 but considered fit for intensive chemotherapy, we utilised a 5+2 regimen, which was a 5-day infusion of Ara-C in combination with 2 days of idarubicin at a dose of 12 milligrams per metre squared on day 1 and 2. In terms of trying to combine this with venetoclax, we had to look at several, mechanisms of trying to reduce the potential risk of tumour lysis syndrome and other toxicities. So what we integrated into this trial was we had a 7-day pre-phase with venetoclax, where we did a venetoclax dose ramp up as a single agent, made sure there was no tumour lysis syndrome with that, and then continued the venetoclax for 7 days. On day 8, we then introduced the first of the chemotherapy drugs, which was cytarabine, as the 5-day infusion. And on day 2, after that, we commenced the second intensive chemotherapy drug. And so that way we had a staged introduction of each drug, which would then allow us to isolate the risk of TLS to one drug rather than giving everything simultaneously. We have enrolled 41 patients onto this study, and our conclusion so far that the regimen is definitely tolerable. We managed to escalate venetoclax to 600 milligrams for 14 days, 7 days before chemo, and then 7 days with an overlap with chemotherapy. The complete remission rate that we observed from these 41 patients was 71%, which is a very promising response rate in this elderly population, which was a very poor risk group. We had almost half the patients had secondary AML, and a large proportion of patients also had prior exposure and failure of either hypomethylating agents or low-dose Ara-C. There were also 3 patients with a prior history of myeloproliferative neoplasm transforming to AML, so a very poor risk population. So our goal now will be to follow these patients up and to see what the long-term outcomes are, but certainly I think this paves the way for introducing venetoclax into intensive chemotherapy combinations now for potentially younger patients with AML.